Absolutely.
First of all, I'd like to thank Keki and Cyrus, who are perhaps done such a great job for Indian ophthalmology. Perhaps Keki is the pioneer of phaco in India, taught everyone, including me, how to do phacoemulsification. And the course which they conduct is not only conducting here, but also in academy, ESCRS and ASCRS, and always a hit. I don't think I've seen a better surgeon than Keki Mehta, to be honest to you, in the planet. There's something special about him. He's got God's gift in his hands. And Cyrus, you are also fantastic. Now coming to, let's talk on subluxations. This was a thing which we started, was the trocar AC maintainer. Because when you have a subluxation, and I'll talk of the IOL and of the cataract both separately, you need fluid in the eye. The advantage in the trocar AC maintainer is, if you're an anterior segment surgeon, you can very comfortably place this very easily into the eye, just above the iris. Now you see here a patient with a subluxed IOL. I made my two scleral flaps 180 degrees apart. Once I made my flaps, now the question comes by trocar AC maintainer. You can see this is 0.5 millimeter from the limbus. All you do is go above the iris. Now, when you have this, you are not worried whether it's going to any subretinal space. Anybody can fix it. Now, the next step is to take the 22 gauge sclerotomy. Once you have made that opening, go ahead and do your vitrectomy. Now, luckily for me, this was a 3-piece IOL inside, which is subluxed. So all we need to do is take 2 glued IOL forceps, and the same IOL after the vitrectomy, I am going to externalize. So you see, this is the handshake technique. Moving it from one hand to the other, the first haptic is out, then do the same for the second haptic. And you can see the second haptic caught there and externalized. The whole surgery, you can see how much of time it has taken. Create the 26 gauge needle Gabor Chariot's pocket. Note carefully the amount of haptic externalized. It's a lot. That is what you need to do. Have enough haptic externalized. Now check, do you have any optic capture? If you have an optic capture, please immediately do the phototropioplasty. In this case, if there is none, all you do is take out the trocar AC maintainer. It is self-sealing. You can inject intraocular pilocarpine and complete this case. So now the question comes, how did this patient look at the end of the day? Let's see it. You're applying the fibrin glue, sealing everything down there. The flap has come down. The conjunctiva has come down. And you can see now the clear corneal incision also sealed with fibrin glue. This is the same patient post-operative day 2. You can see the vision is already improved to 6/9. And you can compare it to the pre-operative and the post-operative picture. Once we have done this, let's move to the second problem which we tend to face, and that is in cataracts in lenses, that is the crystalline lens or a cataract, either way. Now, I showed you just simply in a subluxed IOL, but now let's talk about subluxed lenses, that is the cataracts or things like this, like Marfan's. Keki showed a very nice case of the same thing. Another way to handle it is the way we are showing it. This is a large white to white. Invariably, these Marfan's have large eyes. So we are making the flaps vertical, 12 o'clock and 6 o'clock, because that's the shortest distance available for us there. Once the flaps are vertical, rotate the patient so that you are now sitting temporally, because the correct shake for handshake is basically you got to sit at 90 degrees from wherever the flaps are. Otherwise, your handshake technique will not come very well. Here you can see now I'm making my second flap there. Now I will rotate the patient. In this case, I'm going to show you an infusion cannula, same trocar, but going into the pars plana. You can fix this very comfortably here. I showed you trocar AC maintainer. Now I'm showing you infusion retinal cannula also. Now the next trick in these large things is to watch this technique which we are doing. After the vitrectomy, I'm going to make a small iridectomy in the area of the scleral flaps. The reason is very simple. I told you before, it's a large eye. So by doing this, I'll be able to come more anteriorly and make my sclerotomy more anteriorly and without any damage to the iris. Because now when you go into the 22 gauge sclerotomy, it will go from sclera into the iridectomy and come into the vitreous cavity. That's what you're going to see just now in a second. There you can see Once you have done that, I don't need this lens and I don't need the bag at all. All it will do is give me disturbance. Remember one thing, these are progressive conditions. By fixing endocapsular rings, etc., we can do them. The problem is, after some years, they will lie on the retina, 10 years down the road. So advantage by this technique is, on the glued IOL, is it is permanent. Those lenses obviously cannot move because we are already fixing them permanently inside. So I don't need this lens matter or any capsule also when I'm doing this case. So all I've done is knocked it all off. Once it is got knocked off, now I go in to take my IOL inside. Take a lens of your choice. I prefer the J&J 3-piece because the haptics are extremely good. Now go in with the glued IOL forceps. Watch carefully now. I'm going to catch the haptic. Once the haptic tip is caught, there it is caught, ask your assistant to inject. So the assistant is injecting. Wait for the lens to unfold. When the lens unfolds, now pull out the haptic. Till then, don't pull it out. Now you do the handshake technique. All you do is flex it from one hand, go inside, transfer it now to the other side through the side port. You have taken the glued IOL forceps. Now the first one again goes through the sclerotomy, through the anterior sclerotomy, catches the tip of the haptic, as you can see there. And once the tip is caught, then you externalize. So that completes this both the haptic externalization. Look at the time you have taken, nothing much. Now see carefully the amount of haptic externalized. Remember, it was a large eye, but we have a lot of haptic externalized. So once we have done that, now you have nothing else to do except tuck the haptics inside. So all you do here is take the Gabor-Chariot's tunnel, tuck it inside, and simply glue the case down. I thought I have just a couple of minutes, so I'll just move on to the next thing which I wanted to show you is in the scaffold technique, basically, because this is what Keki also was perhaps the person who started this primarily, was using the simple system of using the HEMA shield there. But when you have a rupture like this and a subluxated cataract, remember one thing, here you can see I'm fixing my trocar AC maintainer so that I have fluid in the eye. Now, once you have done that, do your vitrectomy. Now, very simply with this is, all you have to do is take your intraocular lens and implant it inside in such a way that you're above the iris, but behind the nucleus. And you can see I'll be doing that just now. But remember, take a 3-piece IOL. Once you have taken the 3-piece IOL, the rest of the surgery becomes extremely easy, because all you have to do is, you have now got a very comfortable posterior capsule of your own. All you need to do is go in with a phacoemulsification and emulsify this down. So that is basically the principle of IOL scaffold. And I showed you that in a simple case like that. I thought I'll just show it to you also in the last clipping, which I thought I'll just show you here for a second. And that is again to show you the IOL scaffold technique principally here. But what I wanted to show you here is, here you can see the patient has a PC rupture. All I do is fix my infusion cannula and I'll bring that piece up anteriorly. I wanted to show this on an animation. I've shown you the actual surgery, but here you see on an animation, we are bringing it on a PAL technique, the nucleus, which is perhaps might be about to sink down, doing some vitrectomy at the same time, bringing it up anteriorly. Once it is brought anteriorly, again, as I showed you in the actual surgery, inject the 3-piece IOL into the sulcus or above the iris. Call is yours. You can keep one haptic outside also. Take in the phacoemulsification probe and emulsify this. Now you can use the same lens, put it into sulcus if you have, or glue it inside. Call is yours. So I'd like to thank Keki Mehta for inviting me for this lovely course of his on subluxated cataracts, lenses, and IOLs. I think this course has always been a success everywhere Keki holds it. And to be honest to you, he is the pioneer in all of this. Thank you very much, Keki.
Thank you. Thank you very much, Amar, for being with us. Your coming always makes the difference.
So basically, as I was saying just before also about Keki, I thought I should say a few words on even Professor Lahane and Ragini, because I think the amount of surgeries which both Lahane and Ragini have done together, Keki, I think you'll agree with me, is really huge numbers. I'm not so sure anybody else, even the country, has done that many cases and with giving such great results. On top of that, Professor Lahane is a COVID warrior, right from the top to the bottom, fighting for Maharashtra and the country, you know.
Yeah.
I think that's something really, we have to commend them both for it. So let's now talk on subluxated lenses and cataracts more. See this particular case, that's the intraoperative view. There's a massive subluxation. Now, I showed earlier to Keki in your course, the glued IOL. Those are what we would use for progressive conditions. If it is not a progressive condition, again, I repeat, for a progressive condition, I will definitely go in for a glued IOL. But if it's not a progressive condition, another way, there are many ways to skin a cat, as you all know. I've done the rexes. Watch carefully. I made my scleral flap exactly opposite the maximum area of subluxation. Now you go in with a sclerotomy needle and just go in from the sclera into the vitreous cavity there. Now the game plan is very simple. This is a paper clip capsular hook. Now what we are going to do is we are going to take this inside, and it is made of PMMA. It's made by Morcher. To be honest to you, this innovation was Susan Jacobs, and I'm going to pass it through that sclerotomy. Now, if you realize this clip, it's like a paper clip. So it just latches onto the rexis margin. So you need a good rexis. Remember that you can't do this if the rexis is not there, or if you have a torn rexis. So that's made of PMMA because we found it gives better strength. It locks onto the rexis margin the way I showed you just now. So now, just to be on the safer side, we are also fixing capsular hooks. But remember, these are temporary. These are not going to be remaining inside the eye all the time. This is just for the surgical time. The paper clip will remain permanently inside the eye. Now you can pull this as much as you want. Here you can see on the animation, and that's the best part of this capsular hook. I can pull it as much as I want. You can see now, even when you fix it, if you fix with suture, the problem is the suture can be too tight or too loose. Here, there's no issue there because you can tuck as much as you want. So here you can see we are bending it, flexing it inside, and as much as you want, we can tuck or you can untuck, depending on whether you want to make it tight or you want to make it loose. Now, once that's done, the next step is to do the phacoemulsification. But remember, now I have a full bag intact. So it's not a problem at all in how to manage this case. Here you can see I'm just managing this whole thing fully there. And once my nucleus is gone, now I have given radial support. Remember that. So I need to give a circumferential support. So I'm using this endocapsular ring inside the bag there, which gives me a full circumferential support. Now I go in with the IA and remove the cortex. It's very easy to remove the cortex. Now the final portion is I take off the capsular hooks. As I told you, they were temporary. They don't need to remain in that eye. Now you put any lens of your choice. Here we are putting a 3-piece IOL. But to be honest, you have a bag fully intact right now, which is fully stable with a glued capsular hook. So you can just put any lens of your choice. Now look at how the case looks when it's completed. All I need to do is do stromal hydration here, apply the fibrin glue and seal the portion on the top there. And that seals this case there. So the flap goes in place, the conjunctiva is in place. Now the question comes, how did the patient behave? And you can see here post-operative day 1, vision is 20/20. You can see the capsular hook present there. We also published this subsequently in the JCRS, and the American Academy in the global contest, this won the grand prize. So Susan had won it, I think it was the second AO global contest in which we won the second prize. Do we have time or shall I close up right now, Keki?
Carry on, carry on. Carry on.
Okay. So now since we have, I thought I'll just show you something else. Now you see another problem which we tend to face is this, which we face here. And that is if the patient develops a drop. So when the subluxation is massive and sinking inside, then you are in slight trouble there. And you can see that's where the subluxated lens is lying there. What I'm trying to do is I'm trying to catch it with the vitrectomy probe. I made my flaps ready. Once I have caught it, I'm trying to bring it up anteriorly, but it is breaking a little bit. You can see there. So a lot of cortex also comes with it. All you need to do at that stage is knock off the cortex. Once the cortex is out, then we are much safer there, and we continue the vitrectomy. The nucleus is also just behind the iris there at that stage, and it can just come out with the PAL technique. Once I have brought this subluxed cataract up anteriorly, and I'm going to place it above the iris. Once it is above the iris, I'm much safer there now. All I need to do is then implant my 3-piece IOL. So here you can see I'm implanting my 3-piece IOL above the iris. Remember, it goes above the iris, but behind the nucleus. The idea is very simple. We are going to lock onto that area so that the IOL acts like a posterior capsule. So you can see the nucleus now is lying above the intraocular lens. All I need to do is, once my one haptic is there, then I will put in my second haptic. Here you can see the second haptic now going into the area there above the iris. Now you go in with a phaco probe, and I'm using my air pump on. As you can see here, we have gas force infusion. So the endothelium is very well protected. Once the nucleus is removed, now use iris hooks. So now I'm using iris hooks to dilate that pupil to see if any cortex or anything is inside. It's not there. But now see, do you have lens or rexus or no? In this case, you can see I have no rexus worth the name. So all you need to do is stabilize this lens with the glued IOL technique. The lens is lying in the AC. All I need to do is transfer it from the anterior chamber to the posterior chamber. How do you do this? Use the handshake technique. So I'm transferring it from one hand to the other and catching the tip of the haptic. Once the tip of the haptic is caught, you will see I will externalize that haptic. Now, once my first haptic is out, I then subsequently go ahead and do my second haptic. And you'll see that's happening just now. The final portion is to see both haptics externalize. Remember, when you're externalizing this, you got to catch the tip of the haptic. If you don't, you'll be in trouble. Now, look carefully. The tip of the haptic is not caught yet. So I'm transferring it still. I am in no hurry till the tip is caught. I will transfer from one hand to the other, still some more, till the tip is caught fully. And once that is caught, then only I will pull it out. Once both haptics are pulled out, you will see for shortage of time, I'll just move this a bit forward here to show you the tuck. Now remember the final portion. We do the single pass 4th-row pupillasty. In subluxated cataracts or subluxated IOLs, this is an integral portion many times because you might get an optic capture in some cases and you don't want that. So from one side, you pass the straight needle. From the other side, you have a 30-gauge needle through a paracentesis. Remember, paracentesis is only on one side. Then all you need to do is do the single pass. Once the single pass is done, you will see, bring out that loop out. Once the loop is out, remember the number 4. 4 times you do it and pull it, and you'll see how the case looks when it's completed. And that's the case completed. The rest of the procedure is very, very simple. All I need to do is apply the glue and seal everything down. So, Keki, I'd like to congratulate you again for this lovely course of yours. If anyone has any questions, we have, I think, a couple of minutes left. Please ask.